everybody. My name is Elin Kondrad. So I'm the program director at the St. Joseph Family Medicine Residency in Denver, Colorado. And I am going to talk a little bit about using electives effectively today. What I'd like to start with today is first doing some introductions, and then I'd like to go through some of the key points from the webinar that hopefully at least some of you had a chance to watch before today. But if people are willing to go around, and what I'd love to do is have everybody tell me what your name is, what program you're from, what role you have in that program, and then kind of what level of knowledge each of you has with competency-based medical education, and what you're hoping to get out of today's discussion would be really helpful for me as we move forward. So I will go ahead and get started. So as I said, Elin Kondrad, I'm the program director at St. Joe's in Denver. I am not, despite leading this discussion today, I would not describe myself as a huge expert in using electives effectively. I think there are some things our program's doing well and some things that we still really need to work on and step up. And so I'm excited to get some input from different programs and different folks in the group about what is working well and not working well for them in their scenarios. I would describe myself as kind of an intermediate CBME user. I've as a program director, have spent some time getting myself familiar with that. And I would say our program is still kind of in beginning stages of really implementing a lot of the tenets to really, I think, maximize use of CBME in our program. I am going to go ahead, and what I'll ask people to do is just kind of popcorn to the next person on their screen. So for me, that's Tanya. Tanya, if you're willing to introduce yourself and tell us a little bit about where you're coming from and what you're hoping to get out of today, that would be great.
Absolutely. And I'm sorry, guys, I because I have the PowerPoint, I can't see many folks, but so I'm Tanya Reyes. I am calling in from Espanola, New Mexico. And there's quite a bit of us on the call that are from our new program, Médicos del Centro. So brand new, we're getting ready to have our second class start with us in the summer. And so I'd say that although we're working with it in terms of our curriculum, pretty new, pretty novice in terms of CBME, but wanting to definitely incorporate that in our program. So yeah, any information that we can get would be very helpful.
Awesome.
Oh, and in terms of my role, I apologize. I'm currently serving as a APD.
Great.
Maybe we can go to Ashton.
Sure. Hi, everyone. I'm Ashton Duncan. I'm one of the core faculty with the Medicos del Centro Family Medicine Residency Program. I think Dr. Reyes gave a good introduction to where we are right now as a program. I'm still starting out. I will give our team a lot of credit, though. I think what was really helpful, especially joining the team when I did back in September, is that a lot of our planning was based with the competencies in mind and being very mindful of what the ACGME has lined out. So while we are new to it, I think we've been very invested in it. So there's a lot of motivation on our side, I think, to continue to build on that. And with that, we can finish off our group with Miss Esther Tipton.
Hi, everybody. Again, apologies. My camera is not working correctly, or at all, actually, or else I would have it on. Yes, so my name is Esther. I am the program manager for Médicos del Centro, and I do have background in competency-based education because I was an educator for about 25 years. And we did a lot of similar, parallel kind of work. And so I'm familiar with that and trying to transfer some of those ideas and concepts over into the residency program. And it's very, very similar in a lot of ways to understanding my design, which is used in a lot of public schools and charter schools. Yeah, so that's my background. And obviously, I'm just looking for ways that we can incorporate it better into the program. And since I have to sign off on any electives that our folks do, I want to make sure I'm getting it and understanding it. How about Belinda?
Hi, Belinda Vale. I'm the chair at the University of Kansas. I think that we are reasonably solid in our competency-based education, and but we tend to be uh, pretty siloed here, and I feel like this is a really good opportunity for us to start reaching out and working with other residencies across the Plains to Peaks area. And how about Lynn?
Hi, I'm sorry I'm off camera. Lynn Jones. I'm the director of the Colorado Association of Family Medicine Residencies. So I work with Elin, Dr. Kondrad, and my interest in this is that we helped put this coalition together, and CBME has been a priority identified by all of us, and I'm interested to learn more about the aspects of it so we can take it to the next steps.
Maybe we can go with Richard next.
Thanks, Elin. I can't see the screen, so.
Okay.
Sure. Well, hello, everybody. Rick Krejci here. I'm the program director for the Dignity Health East Valley Family Medicine Residency Program in Gilbert, Arizona. We are a newer program as well. We're in year 2 and going to be putting in our rank list this afternoon for our 3rd class. So it's all exciting. And like all of us, we're on the road here to competency-based evaluations and want to learn as much as I can as we go through this. As a newer program, our first year and second year residents have a small number of electives, but the balloon of electives is in the 3rd year. And so figure we'll learn what we can today. Thanks. And why don't we go to John?
Yeah, this is John. I'm the program director in Olathe, Kansas for a new program that'll be starting this summer, actually under the Department of Family Medicine with KU under Dr. Vale, who recommended this, and very interested in individualized learning plans and how do we develop the best electives for our patients or for our residents in the future. Thanks.
Maybe Catherine next.
Hi, I'm Catherine Murphy. I work with Dr. Feehan, who just spoke. So we are opening a new family medicine residency in Olathe with the University of Kansas. So also working with Dr. Belinda Vale. Yeah, we obviously don't have any residents until starting in July, but we just want to make sure that we are reaching out to any subspecialist or even within the greater KU area, just to make sure that if our residents have a special interest, we can target, their electives for what they want to practice once they get out. Maybe Sarah, has Sarah Mavis gone?
Hi, everyone. My name is Sarah. I'm a licensed clinical social worker here at Dignity Health Family Medicine Residency, along with Dr. Krejci. I'm part of the behavioral health faculty here, and I just started a couple weeks ago, so I'm really just trying to get a better understanding of residency programs as a whole. So hopefully this is a bit helpful for me.
Great. Amelia, are you there?
Yeah, I'm here. We're with our whole faculty watching. We're just trying to fix some sound issues in a big auditorium where we are. But Southern Colorado Family Medicine, a residency program in Pueblo, Colorado.
Awesome. And then Emily, are you available? Okay. Maybe not in a place to talk or stepped away. Okay. I will go ahead and share my screen again and go ahead and get started. So hopefully most of you had a chance to take a look at the webinar from the STFM CBME toolkit. What I'd like to start with today is just by reviewing some of the key points from that webinar. So I picked out some of the slides that I thought were pretty helpful to me in thinking about some of the basic concepts that undergird using electives effectively, that I hope will be a helpful backdrop for the discussion that I'd like to have after that. So lots of credit to Lynn Bateson and Fred Miser, who are the ones who came up with the majority of the slides that I'm going to use today. You will probably recognize them from the webinar that you watched. Feel free when I'm talking and sharing my screen, I don't have a great way to be watching the chat super well. Feel free to unmute yourselves and jump in with any questions or comments that you have. Yeah, happy to pause at any point. Okay. So we're going to just quickly go through kind of what the objectives are of that original webinar and what I'm hoping that we can have kind of further live discussion about. So we're going to spend a little bit of time talking about how to think about elective time and how both the amount of time that we're using for that and how we think about it may be a little bit different than how we've thought about it in the past. We'll talk a little bit about ILPs and how to start using those and thinking about the ILP as a part of what's driving what your elective experiences are. We'll talk a little bit about thinking about elective time to meet learning opportunities and needs for residents. And we'll talk about a little bit about how to create a new elective and do some elective planning. So just a quick review of basic CBME tenets. So again, the real goal here is to move towards having an approach that's based on outcomes. And so there's less of an emphasis on the exact amount of time that we're spending on things and more of an emphasis on skill acquisition. So instead of saying, okay, this person did a month-long inpatient pediatric rotation, so they're definitely good at inpatient pediatrics now. Instead, we're saying, what are we seeing that shows us that they have acquired the skills of doing inpatient pediatrics such that we feel like they're meeting these outcomes? And so this idea around taking what we want those outcomes to be and sort of working backwards from there to make sure that all of our residents are meeting them. I'm not going to spend a lot of time going through what the individual outcomes are. I think all of you should have access to that in a multitude of ways, including that STFM CBME toolkit, which I think is really helpful. But just wanted to kind of bring a reminder that these core outcomes are a little bit different from the milestone framework that we've all been working with for many years, in that they're really more focused on this idea of entrustment of a physician to perform a certain skill in independent practice. And so what we're really looking at here is what our specialty has developed as a shared understanding of what residents should be able to do when they graduate to be successful family physicians and ultimately to meet the needs of their communities. And so for those of us who are in program leadership, this is really important because what the ABFM has said is that without meeting all 15 of these outcomes, that residents are not eligible for board certification. So there's really a lot of onus on us to be monitoring where residents are at, helping them course correct if they're not on track to meet all of those outcomes, and to get them to the place where where we're able to say that they can before they finish at our programs. So again, I'm not going to go through what the individual outcomes are, but I did want to spend a little bit of time talking about what some of the ACGME language is around electives. So the new requirements that came out and that were implemented this last July have said that residents have to have 6 months dedicated to elective experiences. And so that's a pretty significant increase. Prior to that, our ACGME requirements said that they had to have 3 months. And I think going along with that increase in the number of months is that a little bit of that mind shift from around what the purpose of an elective is. And we'll talk a little bit more about that after we get through the nuts and bolts of this. So basically, what is an elective? It's anything that's not a core rotation that is required of all residents. And so if you are saying that all of your residents have to do 3 months on your inpatient service, 1 month each year to graduate, that's not an elective. If you are saying that residents can choose between a few different opportunities or sort of have a selective, based on everything that I've heard from the STFM, and from the ABFM and from the ACGME, those things are things that qualify it as an elective. So it's really any rotation that's not required of all residents. And again, this is kind of moving towards having a more essential role in resident education, with the idea that we have more time to do that, both to get residents up to speed in areas that they may be coming in behind or not keeping up with their peers or not at a place where we think that they will achieve all of those outcomes. And also, there's more of an emphasis on using electives to help residents prepare for their particular career trajectory. So again, as we think about some of what the ACGME is asking us to do with electives, it's something that is really this team effort between the faculty members, the residents, and the program director. And it's something, again, kind of going back to that, using the IEP and using what their future practice needs are, this idea that this is really driven by what their ILP shows and what they want to do after they graduate. So again, something that is a key component of the skills to become a master adaptive learner. And so I think, you know, there's a lot of this language of the master adaptive learner as we talk about CBME. And I think a big part of what that brings in is the importance of residents being self-directed and with our help, them being able to identify what knowledge and skill gaps they may have and what they need to figure out to get to the place where they are able to enter into a practice that they are wanting to do. So driven by ILPs, address future practice goals, and again, require resident-specific pre-planning of electives. This is one of the areas that I hope we can talk about a little bit more in our discussion, because it's definitely one of the areas that I think can be really challenging is that pre-planning and making sure that residents are really engaged in this process. And then I think the other part that is important is making sure that there are assessment tools so that residents are assessing the elective and being assessed in that. There's some latitude around whether programs need to create electives or whether residents can create electives, and you can do a little bit of both, but ultimately electives have to be approved by the program director, and they have to have specific goals and objectives that go with them. And again, kind of that idea of using the selective time to meet learning gaps for residents who aren't meeting their competency goals. For folks that have specific tracks within their residency. So for example, we have an OB track, a sports medicine track, et cetera. For folks of ours who are in those tracks, we have specific recommended electives that people do as part of that track or area of concentration to meet the educational requirements for those. One of the things that I think is a really big kind of mind shift when we're talking about choosing electives and considering the outcomes when we're choosing electives is this idea of instead of starting with what is this resident most excited to learn about during elective time, which I think, at least in our program, has been sort of the paradigm, to starting with the question, is this resident at the desired outcome, or is the resident on track to meet those desired outcomes that we all have to sign off on for them to graduate and be board eligible? And then this idea of saying like, okay, yes, they are cool. They can go ahead and use this time to enrich their learning in ways that they think are really going to be in line with their ILP and their future career plans. And that's what I think of as kind of like, them exploring things that they're passionate about and really interested in, versus when we say, no, this person isn't meeting the desired outcomes or is at risk for not getting to the place where we want to see them by the end of residency, really thinking about using electives as an opportunity to help close those gaps and get them closer to those desired outcomes so that they can ideally graduate on time and we can say, yes, we feel comfortable that they are meeting those outcomes and can be board eligible. This is one of the things that, again, I think has been a really big mind shift for a lot of folks in our program, because I think we've historically thought about electives as a time to pursue your passion projects and to do things that you're really interested in and excited about. And sometimes there's overlap with that and areas that we see gaps, but sometimes there's not. So, for us to say, this person isn't ready to go do their ICU rotation, they need to use some elective time to do additional inpatient hospital work. When they're saying, well, I don't really want to do hospital work after I graduate, I really want to pursue addiction medicine, and I want all of my elective time to be in that. Sometimes there's a mismatch between kind of where we're coming from and where a resident is at, where we feel like that can get a little bit tricky, but we can talk a little bit more about that later. But I think that is a big mind shift with the new program requirements and with this move towards competency-based medical education, of really using this time to make sure residents are on track to meet all those outcomes. And so some of this is what we consider remediation is, using some of that elective time to meet the outcomes. So individualized learning plans. So again, one of the things that our ACGME requirements now say is that our elective experiences should really be driven by each resident's ILP and address the needs of their future goals. This is a copy of the ILP template that's in the STFM toolkit. I know that it sounds like from the introductions people did that there are people who are at pretty new programs all the way to very long established programs. And so people are probably in different phases with this. But I will say our program has been around for decades, and having ILPs for all of our residents was still a new experience for us. That was something that we usually only implemented when people were needing remediation, or what we called a performance improvement plan. And so moving to having an individualized learning plan for all of our residents is something that we've incorporated over the past year, and we use a slightly different format from the one that you can see here. But I think that this is a really helpful starting place if you are at a newer program and haven't already adopted an ILP format. I think this gives you a really good way to get started with thinking about, like, what is this person's future practice goals, and what do they need to work on for that? But also incorporating some areas that they may need to continue to grow and close some gaps. I'm going to move on a little bit to just touching on some steps in choosing an elective experience, and I'm going to go through this relatively quickly. But I think one of the things that we talked about is really this idea of like step one being the resident and their faculty advisor, or however you mentor, coach, however you guys each of your programs names that, sitting down and reviewing the ILP and deciding, are there areas where there are gaps where we need to use elective time to fill that? And if not, thinking about, great, what are this person's educational goals and their future practice goals, and thinking about how to use elective time to help them get to that place. I think we've all had probably experiences of, we probably all have some established electives or electives that we can see pretty easily how to arrange, and then some others that may be a little bit harder. And so sometimes this requires some legwork on the part of the resident who's trying to develop that, their faculty advisor, and potentially other faculty that may have similar interests or expertise in a particular area, to look either within or outside of the program to get more experience in that area. One of the things that I think was helpful to think about from that original STFM webinar was thinking about purposefully educating residents and faculty on what electives are and what the purpose of electives are, and kind of refocusing that and developing a new shared mental model kind of based on some of the things that I've already talked about, and making sure that that's something that you bring up, whether that's like every year in the middle of the year, whether that's part of your orientation, whether that's something you bring up at faculty meeting periodically, whether that's something you bring up in one-to-ones with your residents, but making sure that people understand what electives are to be used for, and making sure that people have a lot of lead time to schedule these, either to develop a new one or to make sure that the thing that they want to do is going to be available when they want to do it. A lot of places will have databases of available electives. We have a big spreadsheet of electives that people have done, and we have a faculty liaison for each of those that we keep updated about every year. We'll kind of check in with the person, or the faculty liaisons will check in with the person on the other end of that. So I'll reach out to our nephrology contact and say, hey, are you still willing to take residents? Are there certain months that you can do that? Here are the goals and objectives we had. Does that still seem like those are reasonable for them to meet with this experience? And who should be filling out their evaluation and things like that. But having that kind of database and thinking about how you're going to structure those, I think can be really helpful for residents. And again, this idea of having tracks for electives. We have tracks within our residency, and then we also have some what we call elective tracks, where we say, okay, you're really interested in pediatric care. Here are some electives that we think would be really helpful. Or for folks who are really interested in doing OB, here's an elective in OB ultrasound that's been really helpful for folks. Here's how you can do an elective with MFM, and things like that, where we'll have 3 or 4 suggested electives for folks who are either in one of our tracks or who just have a particular experience that they're interested in getting, or particular niche that they're interested in. And then as we think about, how are we meeting the needs of our community? We've developed some electives in language study. We have about 40% of our patients are Spanish speaking only. And so we've developed some electives around that. And so I think there are different ways that each of us are probably developing electives that go along with the needs of our local communities and where we see many of our residents going. So again, when we think about what the requirements are around electives that we develop, they should have written goals and objectives. They should be supervised by a member of the faculty. They should have a way that that resident is being evaluated and is given the opportunity to evaluate that elective. And you should make sure that that's something that you have resources so that those things can all happen. I'm not going to spend a ton of time on developing a new elective experience because I think we've talked a little bit about what goes into that. But I think, making sure that that's something that residents and faculty are getting the approval of the PEC, I don't believe is a requirement, but I do believe that that final program director approval is something that's required for elective experiences per the ACGME. So that was kind of a whirlwind through what what the webinar covered and what I think are some of the high points and like key messages of that. So we have more elective time than we used to, but there's been kind of a shift in what the understanding of how we should be using electives is. And that move towards using the residents' ILP and their future practice goals and areas where they're not meeting core outcomes is a much bigger deal. Thinking about that being developing new electives and deciding on electives as being kind of a team effort between residents, their faculty advisor, and then ultimate approval by the program director, I think is a helpful framework to think about. And then remembering that you're meeting all of those requirements of having the written goals and objectives, having a way that people are going to assess and be assessed on that, I think is also really important. And so I wanted to spend the rest of the time that we have together just hearing from different folks about how this is going for your programs. And I'd love for people to just kind of come off of mute and either ask questions about things that they have questions about, share things that have been real successes for your programs. And I'd also love to hear what challenges you're facing and see if that's something that we can get some wisdom from the group on.
Well, I'll just start off by saying thank you for the presentation. It was very helpful and a very, I think, important reminder of the core competency requirements at the end of residency in order to have these folks graduate. And also thinking about electives, I think we've taken a more of an approach of, hey, what do you want to learn about and go for it, which, is kind of typical, I think, thinking about electives. And this idea about using the electives to shore up gaps, I think is really important. And I'm glad I'm hearing this presentation before we have third years, because it's pretty timely. We have actually gotten creative using some elective time for folks who may have been struggling academically, passing step 3 or level 3, and things like that, as well as with around paternity leave. In our institution, we haven't had any maternity leaves yet, but I'm sure that'll be coming. And so it's nice to have some flexibility that you can work with. That's all I got.
Yeah, thanks for sharing that. Yeah, I think that's it is helpful to kind of have a little bit of a reset going into having third years. And I think for all of us, it's been really this sense of like we've encountered the challenge of having residents talk about like, you're taking my elective time away to make me do something that in an area that I'm behind, and that's not fair. And I think that it was really helpful for me to kind of delve more into these requirements and kind of the mindset of the ACGME and the ABFM around this time, because we're still calling them electives, which kind of suggests the resident gets to pick what they want to do. But I do think there's really a pretty clear message that these should be being used to help to make sure residents are on track.
Yeah. Yeah, I think the idea that an elective is something that not everyone is being required to do. I think that's a very good and helpful definition.
Mhm. I'd love to hear from folks at other programs. Anybody else who has success stories, things that are going well, or things that you have found really challenging with this, or questions for the group.
I had a question, just kind of about the either study electives or like maternity paternity electives. Has anyone had successes with um, like advocating for your residency against like the C-suite? Kind of like this is part of their training, something that needs to be done for their training when the C-suite is looking at a resident like, oh, they're just studying, like. I don't know. That was a struggle I've had, and it was hard getting through that, I think. But yeah.
Yeah, that's a great question. Has anyone had experiences with that they'd like to share with Amanda?
I could say that we have done that and it has been fairly successful, but I will tell you that we're in a large academic setting and there are a lot of residents and so the C-suite isn't usually aware of where all those residents are, and we're above our cap, and so they kind of don't recognize sometimes that residents are not, actively on site working, making money for the hospital. And so it's been easier for us to do that. And I think when you're in a small situation where they know exactly where your residents are and whether or not they're making money, it's probably significantly harder to make that case.
Yeah, I think we similarly have been able to mostly kind of fly under the radar, if you will, with that. We offer a parenting elective when folks come back from parental leave where they're in a pretty limited amount of clinic each week, and then they're doing kind of home self-study the rest of the time. And that I think has been a really successful way to help residents re-enter and kind of limit the weeks fully away from clinic per the BFM requirements, but still feel like they have a little bit of a cushion and adjustment time to coming back full time.
Yeah, that's what we do as well. So they do some clinics or otherwise then they're outside of the requirements.
Any other folks that have had experience with this?
In a prior program I worked in, we did a similar thing with residents who were away for, it was maternity leave or, re-entering, as you said. And we were a fairly small program. So one of the ways we kind of got around that with our C-suite, as you'd say, was we almost listed it as a research elective. Residents were required to turn in a report, basically a self-written self-report at the end of every week on what they had accomplished, basically. And then that way, if the C-suite or the higher ups requested, what was that resident doing, we had something to show them.
Any other thoughts on that? Any other questions or things that people are struggling with?
I wanted to chime in on our side. So about out in New Mexico, so we recently had a situation where our behavioral health faculty needed to step away for some urgent family matters that had come up. And one of our core rotations during our first year is behavioral health with him. So one of the things that I think we were pretty successful in our situation is we had one of our one of our interns whose rotation was going to be affected. So as a way of really trying to offload what was going to be expected of him going into these next few weeks, we arranged for a research elective for for our resident that was going to be on with him during this month. And I just wanted to mention it because I think one thing that was successful for us in that situation was kind of having a good sense of what our faculty's bandwidths looked like, what their skill sets were, what were things that they could bring to the table. It's going to go into that point of having the resources to support resident education. Because for something like that, I already had a project that was already halfway in development, pretty well already had some objectives outlined. So then it was just a few quick conversations with the resident, making sure we were in agreement about what that would look like, developing a schedule, and then we were able to bring that together. We are a pretty small team, so I think that one was pretty important. But one thing I'll put in a plug in for that I've done with organizations in the past is asset mapping with people who are a part of it, just to know who can bring what to the table, especially if situations like that arise. Because in this case, it was a matter of introducing an elective to help offset the schedule for a resident, but still provide a meaningful experience. So that was definitely very helpful going into that situation we faced.
Yeah, thanks for sharing that. I think that that point about being able to leverage what your resources are and what your faculty have to offer is a really important one, particularly if you are trying to maintain most of your electives kind of within your hospital or clinic system. You really have to make sure that you have, that you're developing opportunities for folks that you can actually deliver on and have support for. We do a mix of that, and then some things where residents are kind of doing more away electives outside of our system if their career needs or objectives that they're trying to meet that we don't have locally. So that definitely takes some additional planning to make that work. One thing that I would say we continue to struggle with is this idea of, now that people have 6 months, making sure that people are planning that amount of time from an early phase or an earlier phase in residency. And we've done some things to try to help with that. So we have like a career development selective that our residents do as second years, where they're doing some kind of work with one of our faculty on, doing some career exploration and thinking about what they want to do. But I feel like we still run into a lot of people who are like, oh, whoops, it's third year and I forgot to plan my electives, or they show up to their advisory meetings and they're like, I don't really know what I want to do. How are other programs managing that? And does anybody have suggestions or things that have worked well within your systems to make sure that you're not, 2 weeks before somebody's supposed to be going on elective and still haven't gotten a plan from that resident about what they're going to do, or you're not just like putting them into clinic because they didn't come up with anything? No one? Come on. Help me out here, guys.
We have had a problem with that in the past, but if you make it uncomfortable enough for them, so if you don't want to pick an elective, you can just be in clinic every day. That usually is incentive enough to pick an elective.
How far in advance do you require people to have their elective plans submitted?
I won't be the best person to ask of that because I'm not the residency director anymore. So, the very bare minimum is 3 months. We really need it longer than that. But if it's not at least 3 months, it's way too disruptive to clinic.
Yeah.
So we'd like 6.
We also require a minimum of 90 days notice, but we all tell the residents up front that, the earlier the better. And if they get in their requests when that particular attending or service is not available to them because somebody else beat them to it, then it's kind of first come, first serve. So our residents seem to be pretty motivated to get the request in early.
For folks who are at some of the newer programs, I think several of the programs talked about, having their first class or their second class or kind of being in development. How have you developed electives? Is that something where you have a database of electives for your residents? Is that something where you're kind of developing them as you go along and there's interest, or what types of strategies have you used around that?
For us, we have not accepted our first class yet, so we're putting in our rank list now. They don't have any elective time in their intern year with us. They will have some during their second year. So we haven't necessarily gotten to planning that part yet, but certainly I think our program director and associate program director have been in the community for a long time, so they know a lot of various specialists in the area or contacts if a resident has a special interest. I mean, you've all been through interviews recently, so they all think they want to do sports medicine or geriatrics or whatever, and that may change. But I do think it's something that probably that subject needs to be broached early on to say, hey, you need to start, as the year goes, start thinking about what you want to do, so that we can reach out and make sure that that is an option for you come next year if that's what you want to do.
So we're a program that's in year 2, and we actually, the year before our first class came, we started to address the issue and looking for various elective options for our residents and calling meetings with people who are agreed to meet with us and coming up with goals and objectives and whatnot, and then having a menu of options for our residents. And that was really helpful. We certainly add to it because residents come to us all the time with other things they would like to do, and we try and support that as best we can. But for the last individual, I would only encourage you this time between now and when your first class starts. You've got more time now than you're going to have once they do. So it's not a bad item to look at right now. We were glad we did.
Absolutely. Just to echo that, Doc is using our community. And so we have a community hospital here. So a lot of those subspecialties that we have just fostered relationships with and working with that when the time comes. Near future, really near future. And then having the opportunity for whatever they might want. And specifically, like was mentioned earlier, Spanish immersion kind of rotations.
Yeah, this is John with the Olathe program that's starting this summer. What we're planning on is with their onboarding, we'll identify what their goals are and start there as far as developing plans for electives, recognizing their goals may change, but we'll still evolve those as their growth evolves.
Yeah, I think one of the things that several of you have pointed to that's a really important part of that, particularly when you're at a community-based program like I am, is that relationship building with specialists and other community resources to make sure that you have those bridges built so that those opportunities are available to your residents when they are ready to avail themselves of the opportunities. I think that's a really important thing. And then Esther just made a comment that one thing that can help guide the development of elective is a template that's consistent and clear. Yeah, I think that is really helpful. And that if that's something that you're willing to either post in the chat or maybe send to Lynn or Amanda to kind of send out to the folks that attended today. I think that might be helpful for folks to see. I think the more we can share that type of information, I have gotten really good ideas from other programs, and it's definitely not worth reinventing the wheel if you have if you have something that's working really well. Yeah, and I think that idea of having a clear, consistent template. One of the things that we have struggled with is we have gotten a little more loosey-goosey with our with holding people to using that consistent template, and I think that's something that we really are trying to work on getting back on track with, to make sure that we are holding people accountable far enough in advance and doing a good job with having that be implemented equitably across all of our residents. Okay, we are pretty close to time. I think we just have a couple minutes left. Any last minute thoughts or questions or things people wanted to share before we wrap up? Okay. Well, thanks so much for joining us today. And just a reminder, Amanda just put in the chat when our next faculty development webinar is going to be. So that's March 5th. And I think that, Lynn, can you remind us what the topic of the next one is? I forget.
I need to look it up.
Okay.
I know for March, it's just a NMPCTC. I don't think Colorado's in on that one, but you're all are then welcome to join us. But the next Peaks to Plains is going to be April 25th. Competency-based goals and objectives.
Oh yeah, that will probably also be very helpful. Okay, so yeah, just a reminder to folks that those are coming up, and encouragement to join us for future webinars. Thanks so much to everybody who joined today. It's great to see folks from so many different states and so many different types of programs, and kind of hear what's going on with each of you. So appreciate your participation and joining us today. Take care.